So what are these problems with research? The first is a selection bias, and I actually just gave you an example of a selection bias. And this is when the population that is included in your sample does not represent the population you're interested in. So I'm interested in all children in all of Southern Kayonza, but I go and study children at the hospital. Now, why would I study children at the hospital? Why would I choose to do that? People do this all the time, so why do you think they choose to study children at the hospital versus children in the whole community? Accessibility, right? It's much easier, it's faster, it's cheaper, it's easier to do that, but it will introduce a selection bias because the population you're really interested in, which is all of Southern Kayonza, may not look like the population you study, which is the hospital. So a selection bias is when the population you study does not look like your population of interest. And then there's all kinds of selection bias within that. So one is the use of convenient populations, and that's exactly the example I gave you. The children at the hospital are accessible, so I'm going to study them, but that will introduce selection bias. Another example of selection bias is a consent bias or a non-response bias. So this is an example where my population I'm interested in is the community, but maybe some people say, no, I don't want to participate. I don't want to. You're going to ask me about my HIV status and I really don't want you to know. Or you're going to ask me about my income and I don't want to tell you. And it is possible the people who say, yes, I will be part of your study, will look different than the people who say no. Okay? And so if you have a study where a lot of people say, no, I don't want to participate, you have a selection bias. Another example is a volunteer bias. So I'm going to do a study on the level of interest in research. And I will ask questions to anyone who comes to my class. I will ask you if you're interested in research. Well, of course, you're more interested in research than the rest of our colleagues because you're here, right? So if I let you volunteer, then there will be a bias versus if I just ask anyone in Ringkwabu. You have decided you're interested in research, so if I study you, you will look different than if I studied our colleagues at Partners in Health. Okay, because you volunteered. You said you wanted to be here. And then finally, there can be a loss to follow-up bias. So some of the studies that we'll look at will have a long follow-up of patients. So I want to know how patients who are on HIV treatment are doing after 2 years. Some people will not be in our programs anymore. And that can introduce a bias. Are they not in our program because they moved to Kigali to get care there? Are they not in our program because they died? Are they not in our program because they have defaulted? So not having information on the people that we have lost to follow up could introduce a bias in our results. So all of these are issues of selection bias. The population in our study may not look like the population that we're really interested in. But the question is, what can you do to control for selection bias? So what can you do to prevent it? Or if you have it, what can you do to help you interpret results? So one thing you can do is randomization. So this is particularly if you have an intervention study. So don't let people volunteer. You actually have a group of people and you say, you will get the intervention, you will not. So imagine if we had done this course and I said, okay, everyone who works in Ringkwavu, you are eligible. I'm going to flip a coin. Alice, you're in the course. I'm going to flip a coin. Frederick, you're in the course. I'm going to flip a coin. Chantal, you're not in the course. And so I do not let people choose to be here. I let chance decide if you are here. So you're not volunteering. I would go to Eddie and I say, Eddie, I flipped a coin. You are in the course. Whether you wanted to be there or not, you're in the course. Okay? And so we have a randomization that can help us avoid volunteer bias or self-selection bias. Generally, or sorry, not generally, always, you would tell people about the study and they would decide if they want to be involved, and then you randomize to intervention or control. You can do random selection. So instead of saying, I'm going to choose children who live in Ringquavu, I would say, I'm interested in Southern Kayonza, so I'm going to make a list of all children in Southern Kayonza, and I'm going to randomly choose from that list. So I won't just look at children who are here and accessible, I will randomly choose from all children who are available. Now I can immediately see people going, that sounds really hard, and it is, and that's why oftentimes there is selection bias, is because we cannot afford to do random selection. We can't afford to look at children who are far, far away. Another thing you can do is sensitivity analysis. So let's think about this idea of loss to follow-up. I have two outcomes that I'm interested in. Is the patient who was on HIV treatment alive or dead? But some people have gone and been lost to follow-up, and I don't know what happened to them. And what a sensitivity analysis is I can say, well, let's assume everyone who was lost to follow-up is alive. And let's get an estimate based on that. And then I can say, let's assume everyone who was lost to follow-up has died. And let's get an estimate based on that. And that will give me two extreme values. The worst case scenario, where I assume everyone had died, and the best case scenario, where I assume everyone is alive. And that gives me some range of where I think we really are. That is called a sensitivity analysis. I assume the best of people who are missing, and I assume the worst of people who are missing, and I think the truth is somewhere in between. Okay. So that can be done if people are lost to follow-up, if they have not consented, if data is missing. That can be used to handle the analysis. And then finally you can say, well, these are the people who are missing, and this is what I think happened to them. And then just use what you think to replace what happened. And what you think happened to them could be based on a guess, hopefully not. What you think happened to them could be estimated based on what they look like compared to what other people in your population look like. But you try and get your best estimate, your best guess at who's missing, and use that in your analysis. None of them are perfect, but they're all ways that we can try and address if we have selection bias. A second type of bias that we have is called measurement bias. So this is where I have people who are included, but I don't have good measurements on them. There's some problem with the data that I've collected on them. So there's some inaccuracy or some problem with the data I have collected. And I'm about to give you a long list of measurement biases that we often see in studies. Instrument bias. The instrument was not calibrated. So I'm taking measures of weight on children, and I keep getting a child who is 5 years old and weighs 6 kilograms. And I go, something doesn't look right. And then I go and look at the scale, and I see they did not calibrate. They did not set it to 0. Okay? That is an instrument bias. There's some problem with the way the instrument is measuring. Imperfect test bias. So it doesn't have perfect sensitivity, and it doesn't have perfect specificity. Do you know these words, sensitivity and specificity? Sensitivity. So sensitivity is test positive when disease positive. And specificity is that you test negative when disease negative. Okay? So sometimes our tests are just imperfect tests. Sometimes when I give an HIV test to someone, it says positive when they are really negative. And that would be imperfect specificity. Sometimes it says that they are HIV negative when they are really HIV positive. That is imperfect sensitivity. So they really have the disease, but it says they're negative. Thankfully for HIV tests, the sensitivity and the specificity now are very, very high. But it used to be, 15 years ago, that the sensitivity and specificity were not so high. Okay? And so you have imperfect tests to be measuring what you want to measure. And that can introduce a measurement bias. Expectation bias. So this is when the observer records something more favorably for certain groups because she expects them to do better. So I have two groups, people who come to my training and people who don't. And I went to measure their quality of research. And I go, of course the people who came to my training did better. I expect them to do better. Their quality of research is so much better. And what I write down doesn't reflect what I saw. What I write down reflects what I wanted to see, what I expected to see. Okay, that's an expectation bias. Recall bias. And a lot of times if you look at what people are reporting, they're asking people to remember things. How many times in the last year did you have sex without a condom? How many times in the last year did you eat fruits and vegetables? So people will sometimes have a hard time remembering what happened to them, and that is called recall bias. Observer bias, and this has a special term that you will see in the literature called the Hawthorne effect. This is when people change their behavior because you are observing them. Okay? So I'm going to go in and look at the quality of research that you're doing. And you see me there watching you, and all of a sudden you're, doing good analyses, or all of a sudden you're asking questions in a way that does not introduce bias. So you're going to change the way that you are behaving because I am watching you. That is called observation bias or the Hawthorne effect. Okay? So people who are observed don't act the same way as if they're unobserved. Desirability bias. How many times in the last 12 months did you have sex without a condom? Never. I never ever did that. And I say what I want you to hear, or what I think you want to hear. I don't say the truth. Okay? How many times in the last week did you exercise? I exercise every single day. I'm so fit and healthy. But you're saying that because you think I want you to say that, not because it's true. You desire me to like you. You want me to think you are a good person. And so you lie to me because you want me to like you. And that's desirability bias. And then finally, an interviewer bias. And this is when the person who is asking the question asks the question in the way to get a certain response. So I might say, Neza, you exercised every day last week, didn't you? And she's going to be more likely to say, yes, of course, I exercise 7 days, versus if I say, tell me how many days you exercise. So I ask the question in a leading way. And that's called interviewer bias. So these are all things that will introduce a problem with your measurement. So big issue with measurement bias is in your instrument. And for a lot of us, that's the survey instrument. So when we go out and we ask questions about certain things, and really the only way you can make sure your survey instrument is good is to test it, and then retest it, and then test it again, and to make sure there are no problems with your survey, the way you're asking questions. You want to make sure that you have short periods of recall. Don't ask someone what happened to them a year ago. They probably will not remember unless it's a big event. But things like, what did you eat? How much did you sleep? How much did you work? I can barely remember what I did yesterday. Okay? And so to ask me a year ago is a problem. Make sure you calibrate your instrument. So if you're in the clinic doing a study, make sure you check your tape measure for height. Make sure you check your scale for weight. Make sure everything, all your measurement instruments are working well. You can ask questions in different ways to try and get at the truth. So how many times in the last week did you exercise? In the last 3 days, how many times did you exercise? On average, in the last month, how many times did you exercise? What exercise do you do most often and how many times do you do it? And so you can try and ask these different questions we call it triangulation. So I have this point, and this point, and I try and get to the truth by connecting the points, by asking the question in different ways. And then another way to control measurement bias is to start with easy questions and work your way up to more difficult ones. You don't want your first question to be about how many times they had sex. Okay, that's a difficult question for someone to answer. So you want to start off with, hello, what is your name? Where are you from? Did you go to school? What school did you go to? You want to start easy, and then you start building trust, and they are more likely to tell you the truth. Another way to do this is high level of training and supervision of data collectors. So I can only imagine for Willie and for Daniel, who are in the verbal autopsy program, my guess is you had a lot of training for data collection, right? And you probably get a lot of supervision to make sure that the data is good quality and that there's not a lot of bias. You want to convince the participants that they can trust you, so anything that you can do to let them know that you're there to protect them, that there's no harm. And then finally, to blind participants to whether or not they're part of a study. So you don't want them to know that you're studying nutrition when you ask them about what they eat. Maybe you can blind them to the purpose of your study and then tell them at the end why you ask them the questions you ask them. There's two more biases. I'm going to go through them a little bit quickly because I do want to talk about them at the end. Another one that has not come up yet, so I'm not going to talk about it too much, is confounding bias. To me, it is the most difficult one to understand. And so we'll talk about it, but we'll come back to it. So what is a confounding bias? Let's say I want to look at the relationship between two things. So last week we talked about the relationship between circumcision and HIV. Okay, and I want to know, are people who are circumcised more or less likely to have HIV? The problem is, it is not so simple, right? There's a lot of things that are happening with people besides circumcision and HIV. So an example is age. Age can affect whether or not a person is circumcised, and age can affect whether or not a person has HIV, right? Age is something that is related to both circumcision and HIV. The way we say that in science is age confounds the relationship between circumcision and HIV. Age affects the relationship between circumcision and HIV, or confounds. That's why we call it confounding bias. And we need to control for age. If this is true, we need to control for age in order to better understand the relationship between circumcision and HIV. So if we just ignore age, we will have a bias. If we control for age, then we can remove that bias from our study. There's a special type of confounding called temporal confounding. So here's an example. I want to look at the relationship of my program before and after. So I'm going to say, here is the quality of care before MESH, before mentorship. Here is the quality of care after. And I want to know, what is the effect of that program on quality of care? But there could be outside factors that are related to both before and after and quality of care. So what is something else that could change over time that could affect the quality of care? So there are other things that can happen besides our program in the quality of care over time. So things like other trainings, things like better infrastructure, better clinics, things like losing nurses. These are all things that can happen at the same time as our program that can affect our results. And we call that temporal confounding. Temporal meaning time. If I look at things before and after, there are other things that could be happening at the same time that confound my results. The last one, which we also really haven't seen examples of, is exposure bias. And this is only looking at studies of an intervention. So these are studies where we have one group that has the intervention and another group that does not have the intervention. And I want to compare these two groups. So an exposure bias is when you have an intervention study and you want to compare those who have the intervention to those who do not have the intervention. And the issue with exposure bias is I can say, Eileen, you have the intervention, but she may or may not follow. I can say to Nadine, you do not have the intervention, but she may seek out the intervention. And that's what we mean by exposure bias. So one is contamination. So I'm going to say everyone in Southern Kayonza gets mentorship, and everyone in Curehe does not get mentorship. And I want to compare the mentorship to no mentorship. It is possible that a nurse who got mentorship here moves to work in Curehe. Right? And so she's contaminating. They were not supposed to get mentorship, but she moved there and she is contaminated. Okay? It is possible that I could say this area gets PBF for ANC, this area does not. But it maybe the woman from that area comes to get services at my clinic. And so it's contamination. She's come from a non-intervention area to my intervention area. Another exposure bias is a co-intervention bias. So I'm going to say, I'm going to do mentorship here, and there will be no mentorship. But then UNICEF comes in and they start their own mentorship program. And so they have contaminated, or they've done an intervention and created an exposure bias. I told them they could not have mentorship, and then they go and seek mentorship from UNICEF. Okay? That would be a co-intervention bias. A compliance bias. So I'm going to do an intervention where I want to study the effect of exercise. And I say to Neza, you have to exercise 5 times a week. You are in my intervention group. You exercise 5 times a week. And Neza says, oh, it's raining outside. I don't want to exercise. You know, the weather's not good. And she doesn't exercise. She is not compliant. She doesn't follow the exposure. And then again, you can also have the loss to follow-up bias, which is a bit around the selection issue as well, where maybe people who are in the exposure group are more likely to leave, or people who are in the unexposure group are more likely to leave. If you have an exposure bias, there's not much you can do. Generally, we do an intention to treat analysis. So I said to Neza, you will exercise 5 times a week. And I analyze her data like she exercised 5 times a week, whether she did or not. That's my intention for you, is for you to exercise 5 times a week, and that's how I want to treat you in my analysis. I can also look at the dose effect. So I tell this whole group, you have to exercise 5 times a week. Jean-Pierre exercises 5 times a week. Ignace exercises 3 times a week. Neza exercises 1 time a week. I can see if Jean-Pierre is that much better than Neza because he exercised more. They were all supposed to do 5 times, but they didn't. So I can see if there is a dose effect. And then this last one is like a sensitivity analysis that we talked about before, where you can say the best case scenario and the worst case scenario and see how they're different. So my take-home points for this, and then I just want to wrap up with you having a little bit more time for discussion. No study is perfect. There is not a single study in the world that is perfect. Nothing you will do in research will be perfect. And the more perfect the study is, the more expensive it is. So when I said before you could do random selection, yes, you can do random selection, but they're not accessible. You're going to have to spend a lot of money to get the children. All studies have limitations, and the bigger the limitations, the harder to believe the results. So Nadine, this is a little bit what you were asking, at what point of non-consent do I not believe the results? If there's 100% consent, I believe it more than if there's 20% consent. And I don't know that there's a hard cutoff, but the lower the consent rate, the less I believe the results. And then finally, bias affects internal validity. So do I believe what I saw? External validity is something different. So deciding whether or not the results in Southern Kayonza are believable is a different question than whether or not the results in Southern Kayonza apply to Karehe. And those you have to think about how similar your environment is to that environment to decide if they're externally valid. I'd like us to take 5 minutes to look at the study limitations that they presented in this study. So this study is not perfect, and they described some limitations in this study. So I want you to go through these limitations and say, what type of bias is this limitation? How do you think that the bias impacts the results? And is there anything that they could have done to remove this bias?